Welcome to the HealthiHer podcast. Your host, Dr. Amy Brenner, is a board-certified OBGYN with additional certifications in functional and integrative medicine. This podcast is meant to help women find reliable, relevant information to help them feel better, look better, and live better. Here you will hear in-depth information about hormones, sexual medicine, aesthetics, cosmetic gynecology, and functional medicine.
Hey everyone, welcome back to another episode of HealthiHer. And today we're going to talk about something that is at least new to the Midwest market, particularly the Cincinnati market. And as it relates to medicine, I would say it's relatively new too, even though it's been going on for a couple decades. So my question to you is, have you ever looked down there? It's a private question, and you may have asked yourself in the past, can you improve the look down there? And what I mean by down there, a lot of people will say, well, my vagina. But the vagina is actually the part that's inside where a penis would go or maybe a sexual toy would go. But all of that down there is really called the vulva. And today we're going to talk about one particular part of the vulva called the labia minora, or the smaller lips. And I have a fellow cosmetic gynecologist. He's actually a board certified gynecologist. His name is Dr. David Ghozland, and he's become a friend and colleague, and we have very similar practices. And he's been doing cosmetic surgery and labiaplasty surgery for a really long time. And so today we're going to talk about everything there is to know about labiaplasty, or specifically labiaplasty minora. So welcome, Dr. Ghozland.
Thank you very much, Dr. Brenner. And just by you saying I've been doing it for so long, you just dated me. I feel so old.
Well, you were probably one of the first people, I would imagine, maybe not the first, but you were pretty first to the game to start doing cosmetic gynecology surgeries. Am I right?
I'll tell you how it started. It was actually a funny story because you'll know these people. So I finished my residency in 2005, and I had just started my private practice. I was at Cedars-Sinai in Los Angeles. And one of my medical student colleagues who was doing a fellowship in reproductive endocrinology as an infertility specialist at UCLA called me because we were good friends, and called me and said, look, there's this new thing called vaginal rejuvenation. There's this guy, his name's Dr. Madlock, and there's a lot of controversy over it. And the chairman of the OBGYN department at UCLA wants me to do a committee opinion for our American College of Obstetrics and Gynecology compendium, which is like sort of our Bible. Mm-hmm. And I have zero interest and I have no time. And I don't know, you seem like you're not that busy. Would you be interested in taking a look at this? And I said, yeah, sure. I really didn't know anything about it. And I started doing my research, and I knew on the spot that this was going to be something big. So that's how I sort of put my first feet in the water when it comes to cosmetic gynecology. And the compendium, when it first came out, wasn't really pro-vaginal rejuvenation, because in the very beginning when all this started, and I'm sure you remember, Amy, everybody, all our colleagues, were looking down on all these procedures.
Yes.
And
some still even do, which I think like you need to get with the times, but some still think it's taboo and we shouldn't be messing down there.
Absolutely. But things are definitely changing. So I do that compendium. I learn about it.
You wrote the committee opinion in the 2005?
I was one of the writers on it.
Okay.
And then shortly thereafter, I decided.
And what was the gist of the ACOG committee opinion? What was the gist of the article? That doctors shouldn't be doing this, or
that ACOG didn't support this type of procedure because the evidence wasn't behind it yet, and that they were, it was a very sensitive matter because it was a fine line between, is this considered mutilation, or are we taking away something that nature produced? And are we making patients feel dissatisfied, or are we encouraging dissatisfaction of your own body image? Mm-hmm.
And that was that your opinion in 2005 of what
No,
you
so I
contributed?
handed my research to UCLA and these fellows, and they kind of took it, and then unfortunately they rewrote it a little bit to meet what their chairman's point of view needed to be. And then there was no internet really. There wasn't any really PR, and I was just starting. So it was a very slow progression because I really wanted to build my practice, and I really felt like I needed the bread and butter of straight hysterectomies and myomectomies and surgery. So it wasn't until probably 2013 that my practice really started to take a shift. But around that time, solo practices in Los Angeles were kind of fading out. And I was approached by a larger group in Santa Monica where I practice. And the head of the group said to me, look, we really like you. The nurses speak really well of you, and you have a great personality. We'd love to have you on board, but we checked out your website, and you do these labiaplasties, and we really feel that is going to ruin your reputation in this community. So we would love to hire you, but with the understanding that you'll never be able to perform any of these procedures.
And what year was this?
2013.
Oh, geez.
And I thought about it for literally an hour, because I called my wife and I said, I don't know, this could be a really good opportunity. I would have coverage, and I would have a guaranteed salary, and maybe I'm wrong. And then I quickly changed my mind. I said, thank you, I'm not interested. And in 2017, that same head of the group called me and said, David, do you mind teaching me those procedures? And I just laughed and I said, no, I'm really sorry, I can't.
Yeah.
But anyways, just to tell you, Cosmetic Gynecology has taken a life of its own since then. We've done so many more procedures, and we do really cool things. So I thought I'd give you a little history into my background.
Kudos to you for having that much confidence of when you were first starting out of training with Dr. Alan Sod. It took me, I think I debated about doing it for 3 years before I actually did it because, I mean, he's a world-renowned surgeon, but getting started in cosmetic surgery is, it's an investment to train with him. It costs as much as some college tuitions. And the equipment. And I kind of thought, like, you live in LA, but I thought, well, do women in Cincinnati, Ohio really care about this? And is it going to be worth my, time and effort and learning curve? And it took me a while before I decided to do it. But obviously I've learned that, women are the same everywhere, and people do care about it. Obviously across the world. It's not just a California thing. But it took me a long time because it's expensive to learn this, and also an investment and there's a learning curve for sure.
And look, I think anything that's different than what you're accustomed to is always a little scary. And I think, I was nervous too, and that's why even though I took the course, I went back and continued general gynecology and general surgery for many, many years, just because of the fear of losing our bread and butter and what we were truly at the core trained to do. But I think as gynecologists, once you take these courses and you learn the finesse of plastic surgery and you combine it with your gynecology training, that's what makes us as cosmetic gynecology so fitted, as opposed to purely plastic surgeons or purely just gynecologists. So I think it's really a nice niche to be in.
Yeah, so you bring up a good point of something I wanted to talk to you about is, and we'll get into the specifics of labiaplasty, minora, but you mentioned there's a lot of different specialties that may do labiaplasties, and I actually just I reread your book. I'll just go ahead and talk about your book. Is you wrote a book, Everything You Need to Know About Cosmetic Gynecology. And so I read it a couple months ago when you told me about it, and then I just reread it today in preparation for our talk. It's really well done and really comprehensive.
So the thank you very much, and I have to thank the pandemic for producing this book, because you and I and many people who are just so used to just working so hard and so many hours. It was in Los Angeles when we had a full lockdown. We closed our office for 2 months.
Yeah.
And I was beside myself. I had already cleaned the basement. I had cleaned the garage. I had redone the house. I didn't know what to do. And then finally one day I was sitting there going, man, I miss operating and doing everything I love to do. And I was Googling books on cosmetic gynecology, and aside from a very few medical books that are really meant for a surgeon, there was really not much out there for patients. And I knew that it's such a new field, and terminology can be so loosely used in our field, and people call the same thing by so many different names, that I wanted to put together a book that just went ahead and focused on what I do. And for patients, I wanted to write it for a patient's point of view and make sure they understood these procedures and they understood the realities of these procedures and the expectations and how to prepare for them and what to look for in a good surgeon versus maybe someone that's not so recommended, and to be really careful and do their research.
Yeah, you do a really good job. It's an easy read. I think it really explains it all, of what to expect for the consultation, what to expect for surgery, what to expect for the post-op period. It really does a nice job of going over the anatomy. My experience is most women don't understand the anatomy. Is so many times my medical assistant or nurse will room a patient, says she's here for a labia majoroplasty, and then when I give the patient the mirror and go over the anatomy, she's not here for a majoroplasty, which are the bigger lips are on the outside. She's calling them the bigger lips because it's her labia minoroplasty that are bigger than her labia majora. And so in your book, it does a really good job of something, what you and I think is simple, but explaining the anatomy. Because I even had a patient that was a labor and delivery nurse, and she didn't understand the anatomy.
Well, that's a little scary, but
yeah.
Yes, totally. I see that in my practice every day also, so it's so funny you should bring that up.
Yeah. So what the patient says they're there for, or what is on the schedule, and what they're really talking about are just night and day. So if nothing else, to inform people about the anatomy. And I got this book on Amazon, so it's easy to find. And it's, again, everything you need to know about cosmetic gynecology, written by David Ghozland, MD, and it's easily accessible on Amazon.
Thank you for pointing that out, Amy. I appreciate it.
But one of the things you talk about is, there's a lot of, and you talk about it in your book, there's a lot of different people doing these cosmetic gynecology surgeries. Plastic surgeons are doing it. Regular gynecologists are doing it. Urogynecologists are doing it. And then there's people like yourself that are traditional. You and I we're traditionally OBGYNs, but we've had extensive postgraduate training specifically in cosmetic gynecology. So if you could just kind of give us the highlights of what you go over, because I agree with you completely of how do you find a doctor? And then we can talk about like, what are you seeing when you're kind of touching up somebody else's work or revising somebody else's work?
Great question. And I agree with you. I think unfortunately, there's a lot of people who want to get into this field who maybe don't take the time to really train themselves properly and go out there and advertise that they perform these procedures. And because they're MDs, patients trust them. They have a procedure, and then it completely devastates their life because they end up with a quote-unquote botched procedure. And I talk about this often, even sometimes on my Instagram account, which is who should be doing these. And look, plastic surgeons, I always say, they have amazing technique. I mean, this is what they're all about, making everything look amazing, finesse. The suturing is impeccable, minimizing scars, making everything very symmetrical. And so that's a big plus. And I think for many of them, they do a really good job with labiaplasties. I do talk about labiaplasties are one area that plastic surgeons, I think, can do well in. Vaginal tightening surgeries, I think, is an area they feel very uncomfortable with because they haven't had that training to work inside the vagina. Gynecologists have that training to work inside the vagina, but truly as a gynecology resident, you do very, very little surgery on the labia minora. And oftentimes, at least what I see in my practice when people come in for revision type surgeries, is asymmetry. Suturing, the sutures they utilize are just too large, and so they really leave this sort of bumpy appearance to the labia, or they take too much off and amputate because they don't realize the amount of retraction that happens in the recovery period. And so hence we're born as this perfect mesh that feels very comfortable with the female anatomy. And I want to say that because the problem with plastic surgeons doing this type of surgery, just like if I was doing breast augmentation, there's no reason why I can't do a breast augmentation just as well as a plastic surgeon can if I take courses and I practice. But the reality is you want somebody who can handle the complications and the difficult outcomes or procedures and not get scared about the anatomy or feel very comfortable with the anatomy. And that's why I do think having a gynecology background in cosmetic gynecology is crucial, because this is our bread and butter. We've been trained in this, and we know what to do if there's a complication or if there's a post-operative complication. And that's very important, and it's something I always talk about. It's not just about the surgery, it's about the safety around the surgery. So I do think gynecologists, even though they're trained in the female anatomy, they may not have the skills for that finesse that's needed in these cosmetic surgeries, because at the end of the day, when we perform labiaplasties, we want it to be a surgery that the patient knows we did, I know I did, but nobody else knows the surgery happened. And when they ask me, oh, should I tell my gynecologist? And I say, look, the reality is, I bet you anything your gynecologist won't even ask you about it, because they won't even pick it up. And to say that's a pretty big deal in somebody who's looking at vaginas every day. But the reality is, if you're doing a really good labiaplasty, very few people can actually tell it ever happened.
Exactly.
Unless you know what to look for. So I think finding the right surgeon is really key. And second, I think really finding a comfort level with your surgeon, because you want to really feel like their office is taking really good care of you, and that surgeon is attentive to your needs and responds, and you feel comfortable, because it's a very sensitive matter. It's something that's extremely private, and you want to feel comfortable in discussing any issues with that person.
Yeah, I couldn't agree more. From my standpoint, when I see people that have had a labiaplasty done by somebody else, is I find that they're not addressing the clitoral hood. And what I found is 90+% of the time is I'm also doing a clitoral hood reduction on a labiaplasty minora. And regular gynecologists or most plastic surgeons don't want to go anywhere close to the clitoris. And then the other thing is I see gynecologists using a knife to do this procedure, which is not as fine, or you can't really finesse it and get down to really just precise detail with the instruments that you and I both use. And they leave the appearance of the labia minora kind of chopped off, instead of tapering to where the frenulum is that area of the labia minora where it connects to the clitoris. So they kind of have dog ears. Those are the two main things that I see when people have had it done elsewhere, is they didn't address those issues. And then it looks weird.
Yeah, and I think you're absolutely right. I think that speaks to experience. I think addressing the clitoral hood is crucial, because what I tell patients is this: everything is symmetrical in your body. So if you have enlarged labias and they're protruding beyond your vulva and they're bulky or thick, chances are the same thing is happening with your clitoral hood. And I show them. I show them if I thin out your labias, and this is what it would look like, and then I cover it and I just say, look at how thick your clitoral hood is. It's going. Your point of focus then is going to leave your labiaplasty minora, because that's fixed, but you're going to be obsessed and disappointed with the fact that all of a sudden you've got these, I call them bird beak appearance, because it's just this top heavy appearance of the clitoral hood that's going to really bother you, and you're going to come back in and want to do a clitoral hood. And I think most plastic surgeons and general gynecologists don't address it because they're so nervous about changing the sensation for patients or causing issues down the road or getting sued, that they would rather leave it and not address it. But the reality is they're not really doing a complete surgery, because the whole point is to empower women to feel confident about how they look. And I always tell them, if you only address the labia minora and you don't address something needed like the clitoral hood, you're not really completing the procedure in order to really get that look you desire.
Yeah, I agree. And I think it takes people that have just like, again, that extensive education. And I feel like it was extensive to really feel comfortable operating right around the clitoris.
Yeah, and I agree with you. I think there is a learning curve. You can take these courses, but if you don't put in the hours of doing the cases and really learning and analyzing your work, and even, listen, I think we're all good at what we do because we're critical of our work. For me, we become obsessive compulsive, and I actually joke. It's, as my experience grows, it actually takes me now longer to do a labiaplasty than it did when I first started.
Yeah, same.
And it's so annoying because you think it would, I know exactly, I mean, I can do it with my eyes closed at this point, but the reality is I see things, you're constantly learning. And so I'm seeing things that maybe I wasn't seeing 5 years ago, because I know what the final product is going to look like. If I move my little fine tip Elman Surgitron needle just a little to the right, or bend it just a little to a 30-degree angle, what a difference that's going to make. And so I think that comes with lots of experience, and that's why finding people like yourself, Dr. Brenner, and myself and other cosmetic gynecologists is really important, because you get one shot at this.
Yeah, I like how you said that in your book. Is your exact quote is I wrote it down. Your first surgery is always the best surgery.
Of course, it's native tissue. So
let's back up and go to the very beginning. Is what are women saying to you when they come in, or why would somebody even consider a labiaplasty? Sometimes when I talk to my friends obviously they know that I do this, and they'll be like, I've never even looked down there. But some women, they don't care. They haven't looked down there, but it is becoming a more and more popular procedure. And I think, kind of the age range, at least for my practice, is younger girls and then probably mid 40s. Also, it seems like I have a high proportion of people that are getting divorced, also kind of wanting to kind of change appearances. But what are you hearing of why women and what age that they're wanting to have a labiaplasty?
Yeah, so I agree with you. I think that, first of all, it's becoming more common. And I think because of the internet and social media, the people are seeing images of before and after much more often than they used to. So it's becoming more, they're becoming more aware. I would say that the majority of patients who are seeking a labiaplasty are usually in their 20s to early 30s. However, I gotta say that maybe in the last couple of years, I'm starting to see a big change, and I'm having more women coming in after childbirth and saying, look, I want to get my vagina tightened because of laxity, because of torn muscles or separation of your pelvic floor muscles, and I don't feel the same friction. But while you're down there, can you just touch up? Because I never felt comfortable with it. It's always bothered me in clothes or when I exercise. And so I'd still say the majority for labiaplasty minoras tend to be younger, but I feel like the paradigm is changing a little bit, and it's being accepted now as a really satisfying and gratifying procedure throughout the ages. And I've had patients, actually I had one patient who was 80 years old who came in for a labiaplasty, which is a different, by the way, and it's something we can talk about too, handling somebody who's in menopause sometimes. You have to do, at least for me, I sometimes will put them a little bit on estrogen prior to me doing the surgery just to optimize that tissue quality.
Yeah, I agree. I do that actually on everybody over 40 if they're not taking any hormones, is some pre-op kind of topical estrogen, and to just make the tissue a little bit healthier. But it is interesting. Like I'm a little bit older than you, but you know, and I don't know where the shift came, but like I don't think I started shaving down there until I was in residency. So like mid-20s. It just wasn't a thing versus now like shaving, waxing, laser hair removal, like being aware of that area of our body. Like growing up, I wasn't aware. And I'm 52 now versus most people are very aware of, you know, hair, what it looks like, the color. And I don't know when did it all shift?
Well, I mean, I think, look, this is just my personal thought. I think social media has been a huge, huge game changer for these types of procedures because it's everywhere. And teenagers are on TikTok and Instagram. And before, I think when we first started our social media, we were told, oh, stay off TikTok because the demographic is so young and you're not going to really hit your target audience. But the reality, that's changed already. Your TikTokers now are older, and they are pursuing these procedures, and so that overload of information is on every media platform, and everybody is on their phones now, nonstop, countless hours a day. So it's no surprise that they're coming across. And actually, I've had discussions about this. I think in one sense, it's causing a little bit of body dysmorphism. Yeah. And yeah. I think it's going to have to be addressed at some point because I mean, the amount of plastic surgery being performed, and I'm not just talking about cosmetic gynecology, I'm talking about what is considered normal and sexy now. The really tiny waistlines with the really accentuated buttocks area and the big lips and the overwhelmingly large breasts we're back to. And these 360 lipos everybody's doing. It's crazy the amount of plastic surgery when patients come in for consultations. Usually, I'm not their first go-to. Usually, they've had a tummy tuck or they've had a BBL or a breast aug, and then they come in because they're interested in a labiaplasty. And I'm always astounded at how young these patients are that are undergoing all these dramatic, physically changing appearances. Because they want to be part of that norm that they identify on social media because these people are rolling up in Bentleys and playing rap music and they're super cool. But listen, it's the change of the time. So I think if that's the case, if we can give them surgeries that are done well and safely and in the right hands, then it's the best we can do at this point.
Yeah. So what do you do when somebody comes in for your consult process? Like, what do you typically do when somebody comes in and says, I want a labiaplasty? And then they actually are, that is what we're talking about, is the labiaplasty minora.
Yeah, look, I think with any good consultation, I want to get to know the patient. First of all, it's very important as physicians to know who we're dealing with. What kind of medical issues do they have? Do they have any contraindications to this type of surgery? What medications are they on? For example, if somebody has herpes, I like to put them on prophylactic antiviral medication before the surgery and for the next few days. So it's important to really understand their medical background, what medications they're on, and their motivation for the surgery. Because, look, a lot of times I'll have somebody come in, and I had this actually a few months ago. She came in and she was engaged to somebody, but he's been cheating on her. And this really had affected her confidence. And when she approached him with that, what did he say? He turned around and said, well, it's your fault because I don't feel you down there. Mm. And so she ran into my practice.
When I hear that,
my heart sinks
when I hear that. Something, so we have to be very careful because part of it is being a therapist. And look, I'm not here to do surgery on everybody who walks in the door. I want to make sure that you're having something done that you really need. And that's really important. And I think that goes hand in hand with good qualified physicians that are not going to sell you something because they're trying to make a quick buck. So I really try to understand why they're having it, and if it's an issue similar to that, I'm not a therapist, but a lot of times before I even do surgery, I recommend they seek therapy and understand their relationship before, because I tell them having a surgery is not going to fix your relationship, period. It's not going to make you closer to your partner. It's not going to do anything but empower you if that's what you need. But it's definitely not going to fix any relationship. But once we get past that, I give them a mirror so that we can look together during the consultation, and we talk out loud. I'll talk away, and they know to feel free to interrupt me at any point. Then after the consultation, we talk about realistic expectations, because I think the worst thing you can do is not set somebody's expectations, and in their mind, and this happens to you, and it happens to me all the time. It happened to me yesterday, where somebody says, "Oh, Dr. Ghozland, you know what? I'm really embarrassed, but I happen to be looking for before and after pictures, or I saw this porn star on TV. Can you make me like that?" And you're like, "Well, look, I would love to say yes, but the reality is you're not built like that. And there's no way I can make you look like that." And we talk about that. And we talk about, look, this is what this is what the surgery is going to do for you. Are you okay with that? Because what you're showing me is a whole different person with whole different anatomy, and it's not reflective of what's going to happen to you. And so I think making sure people really understand what the end product is going to look like is really important.
Agree. I use that term too. I actually call it, if your goal is porn star perfect, like, first of all, that doesn't exist, because I guarantee you, like, everybody in magazines, like, they've been airbrushed, and I usually even show some of them my marketing material. I'm like, look, this is me. Like, that's not what I look like every day. Like, this is with professional hair, makeup, airbrushed, like, that's what happens when you're in a magazine, is all of those minor imperfections are kind of, however they do it with photography, are edged out. And so that's not really a thing. We can make it as symmetrical as possible, and much more symmetric than, you might currently be. But, sometimes there's a millimeter off because of the healing process. Or, not everybody heals super smoothly. Sometimes it does go back to that crinkled edges of the labia.
Yeah, totally. And I think you're right. It's just making sure your counseling is really crystal clear for them. And then I have them write down on my consent form exactly the look they're trying to achieve, so that they are expressing it and writing it. And that gives me another layer to discuss it with them, because I can be like, "Oh, well, hold on a second, because here you wrote that you want to have a Barbie look." And that's something you and I can talk about either today or some other time. Our mentor, Dr. Red Allenside, is known for creating that Barbie look. And at least in my practice, to be honest, it's not something that I traditionally push on patients, because I have very mixed feelings about the Barbie look.
Yeah, same. It's not super popular for me. So to back up a little bit, we both learned that, there's kind of 3 levels to a labiaplasty: a rim, just taking the outer dark edges off. I hardly ever do that. The Barbie is where you remove all the labia. I hardly ever do that. And so my most common one is a hybrid, where I remove most of it, but you could see that there's still labia minora. So that's my most popular
And
look.
I agree, that's my most popular look. But just to give the audience so the reason why Amy and I are, and I'll speak for myself, but I'm sure Amy, you feel the same way. This is what I tell patients about the Barbie look. When your labias are really long, or at least you feel that they're really long, they want a drastic change. They want to come in and they tell me, "I want nothing. Take as much off as you can, Dr. Ghozland." And I come back and I say, "Look,
Same.
I'm happy to do that. But once I take it off, it ain't coming back." And so it's really drastic to go from having longer labias to almost having nothing. And as a gynecologist, I still believe that labias play an integral role in protecting the vaginal canal, minimizing infections. And what I tell everybody is, look, do the hybrid. And if at that point, when you're completely healed, you come back and you say, "Can you take some more off?" It'll be my pleasure to take more off for you. And I have to tell you, I maybe have had 1 or 2 patients over hundreds of labiaplasties that have come back and wanted more taken off.
Yeah, I couldn't agree more. I encourage people, if you want more off, we will do that in the future. Um, but also, not everybody is going to look right with all of it removed. Like if their clitoris itself is a little more swollen. Um, Many times people are taking testosterone that causes the clitoris to be a little swollen, or just that's just the way they were born. Is I don't think that looks that good with all of the labia removed. Also, if their labia majora aren't a little fuller, I don't think it looks as good with the Barbie
Totally.
look.
And I think you're right. You have to look at it not just tunnel vision labia, you're looking at it from an entire vulva appearance, which is the right way to do it because at the end of the day, that's how you have to look at aesthetics. It's not just about one tiny area, it's about how does it fit in the big scheme of things.
Right. It's kind of similar to breast dog is, you could have a friend of, well, this is the size she got, but, she's 5'11" and you're 5'2", and like you just need to look at it with the entire person.
Totally agree. And the other thing, I get asked often is, what techniques do you use, Dr. Ghozland? Because you'll read that there's so many different ways of performing these procedures. And I always tell people, and I don't know how you feel about it, Amy, but this is what I tell everybody. It's not so much the technique, it's the surgeon performing the procedure. If you feel very comfortable and you're getting amazing results with the wedge technique, and that's your comfort zone, then probably that's the technique for that surgeon, and they're probably going to apply it to you, and your results will probably be really good. If you do curvilinear as your most consistent way of approaching labias, and you do a really great job at a curvilinear approach, you're probably going to get amazing results.
So for those listening, could you just go over what that means of a curvilinear versus a wedge technique?
So the concept behind wedge technique was, how do you make the length of the labia smaller, but still keeping that external rim as natural as possible? So for a lot of people, they come in and they have a darker pigmentation. They're much darker on the rim of the labia, minora. And for most people, they don't want that darkness. So resecting, doing what you and I do, which is curvilinear, going underneath it and doing almost like a straight down resection of that area, to me seems like the superior technique. Others prefer a natural look using a V incision on the labia minora. And so it just depends on what the final look, the final desired look is going to be, but also depends on the experience you have with those techniques. So in somebody who doesn't do V wedges as much, and I'll use myself as an example, I rarely do a V wedge incision. I get nervous because I know the risk of separation of that wedge technique is much higher than somebody who uses it almost exclusively. And I know in my hands, a curvilinear allows me the artistic freedom of creating the labias the way I believe the patient wants them in the long haul, if that makes any sense.
Yeah. So I've never done a wedge technique. I didn't learn the wedge technique, and at least what I learned and have read is that the wedge technique can be associated with more wound breakdown, as well as, you and I both use the same instrument, the Element Surgitron. I've never done a wedge technique, so maybe somebody that does that technique can, give me the counterpoints, but it just seems like I don't have a reason to ever do the wedge technique, because I feel like I can accomplish what I need to accomplish on everybody with the curvilinear approach. And I haven't met anybody that wants to keep the outer pigment to their labia, even though sometimes it comes back. Most of the time it comes back.
Yeah, and I think I completely agree with you, and I feel the exact same way. I do 99% of all my labiaplasties curvilinear because I feel like the results are better. But because the internet has all this information out there, and they address the wedge technique a lot, it's something people come in asking for. and they'll say to me, which technique do you prefer? Well, how do you perform your labiaplasties? And I tell them exactly what I told you. It doesn't matter. All it matters is that the surgeon performing the procedure does it a lot, gets great results, and has a good reputation.
Interesting. I got to be honest. I don't think I've ever had a patient ask me that.
That's because you're from Cincinnati. I'm kidding.
Yeah. Yeah. They're like, I didn't know anybody did it here. So you and I think we both do it this pretty similar is we both do it in our office. So let's talk about like what to expect on the day of the surgery. Do you ever do it in the hospital?
I think when I first started in 2005, my first initial cases were done under general anesthesia in the hospital. Probably because, one, I didn't have the proper procedure room to do it in my office. I was just starting. And second, I was nervous. I wanted the patient asleep. I wanted to have all the equipment I needed in case she started really bleeding. But I would say 99.9% of all my cosmetic surgery is done in the office, unless, when I used to do hysterectomies, if I was doing a hysterectomy, I would sometimes do a labiaplasty at the same time. But the problem is, in the hospital setting, we don't have access to some of the instruments you and I love to use for these.
Mm-hmm. Yes.
And so I really recommend, and I think it's very safe, and I tell patients, I actually will put this argument to you, even done in a surgery center. This is what I tell patients. And we have a surgery center literally next door to my office. And they ask me, well, I think I want to be put to sleep. And this is what I tell everybody. I think an awake cosmetic gynecology procedure, whether it's vaginal tightening or labiaplasty, is actually yields to better outcomes than asleep for the following reason. Because at the end of the day, it's not only about technique, but unfortunately, it's about money. So a patient has to pay a surgery center a per hour fee, has to pay the anesthesiologist a per hour fee. And normally, you and I would book a labiaplasty for a 1 hour procedure in a surgery center, and that's going to cost a few $1,000s. How upset is your patient?
Just for the hospital, not for the hospital fees, not your fee.
So how upset is that patient going to be if you come out and you say to her, look, your labias were more complicated. It took me 2 hours, and you owe a few $1,000 extra dollars. So what happens is, in order not to get into those situations, surgeons who perform these procedures under general anesthesia typically, in my opinion, work at a faster pace because they're on a time crunch. Where when you and I are doing it in the office, everything is just relaxed, right?
Yes.
Patients are watching TV. Yes. I'm taking my time. Sometimes it takes me faster than anticipated. And sometimes, because we're both neurotic, it takes me twice as long as I would have thought it was going to take me, because everybody's labiaplasties is like fingerprints. Nothing is created equal. And you're trying to make everything symmetrical. And so sometimes there's ridges and unforeseen extra layers of skin that you have to remove in order to get that look you want. Sometimes you're halfway done suturing and you realize, I don't really love the way it looks. And so you take everything apart and restart. Right? And so I think there's so many benefits to doing it under awake anesthesia. And we've mastered it now. You do it, patients don't complain. My patients love it. I get a chance to really bond with them while I'm doing it. I can talk and operate at the same time, so we have amazing conversations. I get to know them on a much deeper connection. They feel more connected to me, which means that they're more comfortable telling me stuff. And that's really important as a physician, because a lot of times what happens is you meet somebody for a consultation, they book the surgery, you take them to the operating room, they're asleep the whole time, you wake up, you say hello, everything went beautifully, congratulations, and you leave.
Yep.
And really, your relationship has never materialized into anything more than a just very superficial, transitional type of relationship. And I feel like I'm really happy that we have gotten to the point where a lot of these procedures now are being done awake.
Yeah, I never thought of it like that, but you're absolutely right. You really get to know the person because you're talking to them for a while.
Yeah, and you know what? Look, what happens when you get to know a patient, and I'll be really transparent. Let's say the patient comes back and says, Dr. Brenner, my left labia is longer than my right labia. I thought you were going to make it symmetrical. But watch this shift in conversation. Now, you've taken that patient in the operating room. They don't really know who you are. They never got a chance to know you, and they're upset. Versus the patient who comes in and has spent quite a long time with you in the operating room. You guys have talked about everything. She feels so much more relaxed with you. She's going to be way more accepting of the fact of you turning around and saying, look, sometimes asymmetry happens because they each have their own blood supply. Everything reacts a little differently. I totally see it. Why don't we schedule you for a revision? I promise you we'll get it right. And they have that confidence in you because they feel like they know you. And so you've established a much stronger patient-physician relationship.
Right. Yep. And that happens sometimes. Like, not often, but sometimes one side, for whatever reason, just gets really swollen compared to the other side. And it can distend the tissue. And it's usually me saying I want to
I know, me too. Isn't that funny? And I've been saying it more. I always look at it like, you know what? Can I just ask you a favor? There's this one little spot that's really I just want to fix for you. Do you mind if I do that? And they're like, what spot?
Yeah, I don't know what
you're
you're talking about.
If you look over here, let me show you with the mirror. Let me show you a magnifying glass. That's because we take pride in our work, and this is what we do. And I think when you get to that level, Amy, that's when you know you're doing the right things for people because you really have taken it to a passion level.
Yeah. It's really fun. I know I need to let you go, but let's just talk about 2 minutes of what people can expect in the healing phase of, because this isn't something, we do today and you're, off to the races and back to life tomorrow. There is some downtime associated with a labiaplasty surgery.
I mean, yeah, I tell everybody, look, there's a few things that I really stress when I talk about post-op recovery. Aside from them getting a very detailed instructions of what their post-op is going to look like, aside from the fact that all patients know they can call me 24 hours a day if they have any problems or complications. So they know that I'm there for them. The first thing is swelling. I tell everybody, look, I call it the first few days my Frankenstein period. Because if you take a mirror and you go home, and everybody does because it's just human nature, for the next few days, you're going to look at your labias and probably cry at what you're seeing because you can't believe you did this to yourself. The second thing, which is really important, I tell everybody, the sutures that we typically use dissolve by themselves. But because they sit in a moist, hot environment and because they're surrounded by your natural vaginal flora, oftentimes they will pick up an odor. And so patients become a little sensitive to that. And I always let them know because if not, I get the phone calls. I think I have an infection. Can you see me right away on a Sunday morning? So that's what I counsel. I don't know how you.
Oh, same thing. Like I tell people, like, you're going to think you have a yeast infection. Like you don't. This is normal. So,
yeah. And what I tell patients is, look, we're going to place you on antibiotics because it's an elective procedure. But if you're delivering a baby and you tear, and you have a first or second degree vaginal tear and you're repairing in the field right after the patient pooped during her delivery, you don't typically place them on antibiotics.
Mm-mm. Knock on wood. I don't think I've ever seen an infection from a labiaplasty.
Never.
Have you? Never.
So that's the good part. And I think, look, on the other side, that's really nice. I think there's low risk of infection, and I think the vaginal tissue is very forgiving. And that's why I think these done in the right hands, you get really, really outstanding results.
Yes. I had one patient that I did her surgery that weekend. She had a house full of house guests. And then 2 days later, she flew across the country for work, which, whenever you fly, walking through an airport, there's a lot of walking at an airport. And so I saw her back at 1 week and it still looked like an explosion had gone off. And so I said, you need to take another week where you're just laying around. But other than that, I usually see people back at a week and tell them after a week you can, live your life. But for that first week, you want to be laying around and watching TV and reading a book and kind of like you would act like if you had the flu. where you're just laying around and letting other people do everything else. So
couldn't agree with you more.
Well, thank you so much to join us. I know if you just want to kind of give a heads up of where people can find you and your podcast and all the things that you do, because you also have a wealth of information.
Well, first of all, thank you so much for having me on your show. I always enjoy speaking with you, Amy. I think you have so much passion in this field that you're doing the right thing for all your patients. I'm going to have you on my podcast. So I have a podcast called Women's Health and Beyond, and we talk about cosmetic gynecology, women's health, and it's something that I'd love for you guys, your listeners, to join and subscribe to. My website is davidghozland.com, and if you're in my area, feel free to give us a call for a consultation. But truly, Amy, thank you for being you and really helping so many women feel confident about themselves.
Oh, thanks for joining us. We'll talk soon.
Thank you for listening to this episode of HealthiHer. You can find us on Instagram, Facebook, and the web. Go to www.dramybrenner.com to learn more. This podcast is for general information only and does not constitute as medical advice, the practice of medicine, nursing, or other healthcare services. No patient-physician relationship is formed. The information in the podcast and any references, material, or links are at the sole discretion of the listener and not meant to be a substitute for professional medical advice, diagnosis, or treatment. Listeners should not delay or disregard obtaining medical advice for any medical issues or diagnoses that they may have, and should seek medical advice from their healthcare provider for any such conditions.